Welcome to the Orthodontics in Summary podcast, where Farooq brings you the key points and understanding of orthodontic webinars, conferences, and papers in a concise podcast with your host, Farooq Ahmed.
Welcome to this episode of Orthodontics in Summary. Today's lecture is entitled Comprehensive Orthodontic Approach of the Excessive Gingival Smile. This was by Mona Ghoussoub. This was a really good lecture. She gave a rundown of the diagnostics with a real focus and emphasis on the treatment planning. The starting off was the definition of an excessive gingival smile at 4 millimeters or greater. That was back with Kokich in 1999. She then went through the diagnostic features, not just looking at the lip length and size, but also the hypermobility of the elevator muscles, and also taking age into account. We know from David Sarver's paper, from the age of 40 onwards, we generally show greater lower incisor show relative to the upper incisor show. And the mainstay of the lecture was the treatment approaches. And Mona divided that with early intervention and late intervention. So the early intervention really relates to the medical side. If patients are showing nasal obstruction, we can see the clinical signs, dark eyes, flat cheeks, increased facial height. We are thinking of referring those patients to ENT, and that's because nasal obstruction has a relationship to reduce lip closure, so then competence may be resulting in the excessive gingival show. Orthodontic early treatment can involve the use of a utility arch to carry out some anterior intrusion. Now, Mona emphasized customized retention for these patients. In an early mixed dentition, we're thinking of having an Essex retainer, but leaving gaps for the posterior molar teeth to erupt and premolar teeth. Now, what about the late treatment? Well, it's divided, with orthodontic treatment to manage it, but also looking at multidisciplinary management for these patients. So starting off with orthodontics, there's 3 key management styles, looking at alignment as a management. Now, this is typically for the Class 2 Division 2 case, where we have excessive gingival show anteriorly and reduced gingival show posteriorly, demarcated by this reverse curve of Spee. And what Mona stated is simply using straight wire, we are able to intrude the anterior teeth and extrude the posterior teeth. Those reciprocal effects resolve the excessive gingival smile. Next, Mona spoke about expansion. So the use of rapid maxillary expansion achieves our posterior dental expansion, but also changes the gingival position. The gingival position goes superior as we expand. This fits my understanding of RME as well, as we also get a rotation of the palatal shelves as we expand. The final orthodontic approach was intrusion of those anterior teeth. We can use conventional mechanics, as she mentioned, using Ricketts arch or the Burstone's 3-piece intrusion arch, headgear with J hooks to intrude the anterior teeth. But also more contemporary measures, such as temporary anchorage devices. And she gave 2 very clear examples, depending on the etiology. So if we have anterior gingival excess, we can use a TAD in between the upper central incisors. Simply attaching power chain to the arch wire intrudes the upper anterior teeth. Next, Mona went on to describe posterior gingival excess in a case where there's an increased overjet as well. Here, a temporary anchorage device can be placed posteriorly, buccally between the upper 5 and the upper 6. Now, to retract the anterior teeth and carry out posterior intrusion, biomechanically this is possible through attaching power chain or some form of retraction mechanics from the upper TAD in the buccal posterior segments to the arch wire in the upper canine lateral incisor region. And the reason why this works are the biomechanics. The center of rotation of the maxilla is above these mechanics. Therefore, we get a rotation of the maxillary plane. We extrude anteriorly, we have to therefore intrude posteriorly as we retract these teeth. So I thought it was a really key use of biomechanics to our advantage in treating a case of changing the occlusal plane. Next, Mona described multidisciplinary management. She started off with periodontics. Now, gingivectomy is relatively straightforward to have carried out, but for the appropriate case, where we've had that passive over-eruption of the upper anterior teeth, but also in cases where the tooth width height isn't ideal, and this can help idealize those average ratios. Next was something new to me, and that was the use of guided tissue regeneration, GTR, for vertical maxillary excess cases. So the background to this is patients with VME generally have a bony concavity in the anterior superior aspect of the maxilla. And that has an effect when the elevator muscles are in use. It results in greater lip rising taking place. So the premise of this treatment modality is to place GTR bone in that concavity region in the superior aspect of the maxilla. In doing so, there is a reduction in the amount of gingival show, and this has been shown to be stable after 1 year and has an improvement of 40 to 60% of gingival show when combined with crown lengthening. And I think that's a really interesting idea that's been put forwards, far less involved than having orthognathic surgery. Which brings us to the next case of having orthognathic surgery with a differential maxillary impaction to resolve the excessive gingival smile if vertical maxillary excess is the etiology. Next, moving on to plastic surgery. So this is a paper by Pierre in 2020 where they looked at the short lip. And this is really designed as a lip repositioning surgery. This was first popularized by Rubinstein in 1973. So what is it? How does lip repositioning or lip length reduction surgery work? Well, the premise is that the smile muscles pull on the upper lip are reduced if the upper sulcus is also reduced in its height. This was shown by Farooq in his 2018 systematic review. So how does the technique work? Well, essentially there's an incision made in the upper buccal sulcus. There's a split thickness flap exposing the connective tissue. Now the mucosa is then advanced and sutured in at the mucogingival junction, therefore reducing the depth of the upper buccal sulcus. In doing so, there therefore is a reduction in the activity or the amount of pull the upper elevator muscles can deliver to the upper lip. What kind of changes do we get? Well, the evidence is a bit sparse, but going back to Farooq's systematic review, it showed there's an improvement of excessive gingival smile on average of 3 to 4 millimeters. Now, the final treatment modality is for the hypermobile lip, again with the plastic surgeons, and this is with the use of Botox. There's a great paper by Senjig in 2020 which highlights this information. And how does this work? Well, the premise is to reduce muscular activity, specific to those muscles involved with elevating the lip, mainly the levator labile superius and the zygomaticus minor and major. Now, what's interesting is that this treatment modality is not classed as an alternative to the other treatment modalities. It's considered as an indication. Patients can get an idea of what it could look like with more comprehensive treatment. And that comes down to the premise of using Botox, is that the effects are temporary, and we know that their relapse will take place at 6 months. There are challenges with using Botox that Mona highlighted. It's a dose-related result. Excessive use of the material can result in paralysis taking place or significant reduction in activity. Too little, we're not going to get the achieved results. If it's not delivered in an expert sense, we can get erroneous smiles and asymmetries can result. I very much enjoyed Mona's lecture. She gave a comprehensive lecture on the topic, but also introduced treatment modalities that are outside of orthodontics. I think it's important that we are aware of them and can suggest them to patients when appropriate. It reminds us that there are limits to orthodontics, and we shouldn't be like the toolsman who only has a hammer, otherwise we'll be treating all problems like a nail. Hope you've enjoyed this episode. Please do subscribe and look forward to the next episode.